the United States. And I don't say that lightly, but really from the bottom of my heart. And for those presenting today, it's really easy to back that statement up. I read the latest blog post from RIPMD with a quote from an RIPMD beneficiary that says, "Receiving this debt relief has been life-changing and a blessing. And out of nowhere, I feel relieved of financial stress and can accept this help to build my credit back up so I can purchase my forever home for my children and grandchildren." I go online and I see Access Health, and what you're doing to empower people and change lives is inspiring. And we're all better for your passion in finding innovative ways to help individuals and communities thrive. And I go to the Facebook page of DuPage Health Coalition, and I see how you're encouraging your followers to be their beautiful selves and reminding them and us to be that. To be beautiful means to be yourself. And your reminder post last Friday sung to me to all of us to be kind to one another, and reminding us that all people deserve kindness, but none more so than the person reading the message that you posted. So thank you all for the work that you're doing in your communities to be change makers, whether you're presenting or joining today as a participant. Our objectives today are a few things. We want to share what we all are doing, CJA, RIPMD, Access Health, and DuPage, what we're all learning about the potential and limits of community influence and power to address medical debt at the local level. We want to give our CJA members today on the call the opportunity to hear from their peers and community experts from DuPage and Access Health on early insights from their work to address medical debt. We want to call out today and surface work that may be happening elsewhere within the CJA network to address medical debt. And we want to pique interest in sharing resources and knowledge about other strategies to address medical debt, from financial assistance screening and referral programs to public policy change. So I know that in this two-part series, you're going to hear and share current and innovative strategies, common challenges, and helpful resources to address medical debt in your local community. We invite you to bring your ideas and questions to the table. Thanks again for being here. Gregory?
Thank you so much, Gary. We will transition now. So I wanted to, for those of you who just joined, we had a few people just join, to reiterate. So the overview for today, we had our welcome and introduction. Thank you, Gary. We're going to transition to two presentations from our partners, who are the community experts on the work that we've been doing in medical debt relief. And then following these presentations, we're going to have a discussion, and then we're going to close out the call. The call will be recorded and will be sent to your email following. In the interim, during the presentations, please refer to the questions by placing them in the chat. We'll be monitoring the chat. Any technical difficulties as well, please just submit in the chat. But we have considerable time towards the end of the call for discussion, where we're going to encourage you to come off mute and really engage in the subject matter. But for now, I want to transition to our two presentations today. So our first presentation is going to be from Kara Murphy, who's the president of DuPage Health Coalition. Our community experts, again, DuPage Health Coalition and Access Health. But Kara, if you wouldn't mind coming off mute and transitioning our call to your presentation.
Sure. Hi, everybody. I'm going to say good morning, because it's still morning for most of us, earlier morning for some. But really nice to see some familiar faces and some folks who I haven't met yet. And aside, I just have to say to our Access Health friends in Michigan that I really love your logo. It's beautiful. But not what I'm here to talk about today. I'm actually really excited to talk about medical debt, coming upon a little bit past a year of our partnership with RIP, and here actually to talk about both that partnership and some other work that has happened in concordance and synergistically alongside our work with RIP. But first, a little bit of background about the DuPage Health Coalition. If I could ask you to advance to the second slide. Thanks, Gregory. So the DuPage Health Coalition, as Gregory shared, is about a 20-year organization. Actually, we were founded in 2001. So we're just a little bit past 20 years old, like many of our CJA colleagues. And the mission of the DuPage Health Coalition, much like the mission of many of our partners at CJA, is really around building access and equity in healthcare for all of our neighbors. We believe that every one of our neighbors deserves access to excellent healthcare. And furthermore, we believe that within our community, that access is within grasp, that we have the asset of excellent care within our community, and that it is, in fact, can and should be available to every member of our community, and that with the work of ourselves and our partners, we can make that possible. The patients that we serve, first I'll just point out that map there to your left. DuPage County is, as you can see, a pretty large county, because you can see it's just about as large as Chicago to its right. It is a community of about 1 million people. It's the second largest county in Illinois, second only to Cook County, our neighbor to our east. Much smaller, however, than Cook County, the city of Chicago. We are a community of just under 1 million residents. Our focus is all of DuPage County, and our mission at the Health Coalition is to serve both the uninsured and underinsured residents of DuPage County, and we do so through a host of patient-facing programs, which I'll detail very, very briefly. But really, mostly our focus is on those individuals who are either uninsured or underinsured, and with incomes typically at or below 2.5 times the federal poverty level. Mostly, and in most of the programs that we offer, our direct patient-facing services tend to focus on those folks who are uninsured in our community, or who need special assistance to be able to not be underinsured. And that means that we are commonly serving immigrants, that we are commonly serving individuals who would represent the working poor. Most of the families that we serve through either our Access DuPage or Silver Access programs are born outside of the United States, representing dozens of countries, but Spanish is certainly the most common language that our patients speak at home. 94 to 95% of the patients that we serve are speaking Spanish at home, and then another 30 languages in addition. English is only spoken by 2 to 3% of our patients at home. So that gives you a sense of just how heavily we are serving a primarily immigrant community. We've served just under 70,000 patients since our program began. On an annual basis right now, we're serving 6,000 to 7,000 patients. Pre-ACA, we were serving more like 15,000 patients a year. I already talked a little bit about the community. We are a dense suburban community. And on balance, DuPage County is pretty affluent, which sometimes causes people to think that there isn't a lot of need here. But that is absolutely an inaccurate statement. Although the median income in DuPage County is relatively high, there are more low-income families living in DuPage County than the entire population of 80 other counties in Illinois. So we have more low-income families living here than the gross population of the vast majority of the rest of the counties in the state of Illinois. But the way that we do our work is also something that I want to highlight in the last piece of this slide. Really, our work, we call ourselves the Health Coalition, and that is an accurate statement. We would not be able to exist. We would not be able to accomplish a fraction of what we do were it not for our partnerships. We partner with every hospital in DuPage County, and there are 9 hospitals here in DuPage, 4 health systems and 9 hospitals. But we also partner closely with hundreds of health and human service organizations, with our public health department, with all of the FQHCs in our community, and also with dozens of for-profit medical partners, hundreds of local physicians, thousands of local physicians indeed, and most of the large for-profit medical groups as well. Next slide, please. So I said that we operated a host of programs. For a long time, we were known as Access DuPage. Many in the community continue to know us as Access DuPage. We're proud of that, and we're completely okay if that's how people continue to think of us. That is our largest program. It continues to be the program by which we're best known. But in addition to our Access to Page program, which coordinates health access for low-income, uninsured, and underinsured residents of the community, we also provide a number of other programs. Silver Access is an ACA premium assistance program, which helps people to purchase high-quality health insurance for which they qualify. The DuPage Dispensary of Hope is a free pharmacy program. We offer a team of ACA marketplace navigators and client benefit specialists to help people to enroll in both marketplace plans and Medicaid plans. We have a new program called Access Fit, which sort of takes the model of Access to Page and applies it to wellness and fitness programming to help link people up to preventative wellness services. We also have a host of health education programs and a new program called Everyday Hero, which aims to counteract some really troubling data around community access to CPR and other life-saving resources by partnering with community organizations and faith partners to expand access to CPR and also install AEDs in disparately accessed communities. Next slide, please, Greg. But here is where I really want to focus our time and attention. And this is on the two different projects that have come together somewhat synergistically over the course of the last year. And I really want to acknowledge the role that CJA played in making this possible. When CJA announced the series of webinars that were available last spring, we were really excited. We had been hearing and thinking and talking about medical debt. Like many CJA partners likely on this call, we felt like we were passively, but in some cases actively involved in trying to manage and mitigate the debt of our patients already. But the processes that we were using were somewhat imprecise. We were helping where we were able, but we didn't have a structured process by which we were helping people to address the medical debts that were mounting in their own lives. So we listened to those webinars, and we had the opportunity to apply both for the funding opportunity through CJA and also another opportunity at the same time. But recognizing that what we really needed to do was understand the full nature of the need that our community was experiencing. The thing that we did first in the spring of 2022 was to spring of 2023 was to launch a survey to all of our members, asking them to provide us some information around the full nature of the medical debt that they had in their households. And that data really, honestly, was very troubling to us because it showed us that while we knew that there was some measure of medical debt, in fact, it was worse than we realized. 79% of the folks who responded to that survey, and hundreds of individuals responded, indicated that they had significant medical debt within their household. And these were people who were enrolled in our programs. So they were already receiving significant assistance that should have mitigated their debts in a significant way. With that in place, we ended up launching a series of programs, including our process with RIPMD, and worked with RIP over the course of the summer to craft a strategy. I shared that we partner with every hospital in DuPage County, and we leverage those partnerships that we have with the county and those long-standing 20-year partnerships with those hospitals to reach out to them and invite them to be a part of this process, hoping that those long-standing relationships would be an effective pathway to be able to gain willingness to have what can be pretty sensitive and difficult conversations. Folks on this call are probably aware that hospitals can be reluctant to talk about debt because oftentimes it's a place where they can feel the sting of being demonized and oftentimes being thought of as bad actors. I'm pleased to report that we had two health systems that fairly quickly agreed to be partners with us in this effort. One, you'll see here reflected on the slide, has come forward publicly, and so I'm happy to share that University of Chicago Medicine and Advent Health has publicly expressed a partnership with us and RIPMD, and in fact has shared a medical debt file, and we're in the process of working through, hopefully discharging a significant amount of debt that will cover 4 hospitals if successful, and presumably impact the lives of thousands of patients. We also have another health system that we are in conversation with. This health system is even larger. It is the 3rd largest health system in the Chicagoland area and would impact millions of patients potentially. This health system covers 3 different counties and in fact has 2,400 beds. And they are, in fact, looking at this as a system-wide initiative. But as a consequence, it's moving very, very slowly. As we talk more about this process, we'll talk about exactly how slowly this can work. I will move on to talking about our second project, but look forward to answering more questions about really the learning of this last year. There has been so much that we have gained from the partnership, and also so much that we have learned in terms of how to gain the acquiescence and, in fact, the enthusiasm of our health system partners to be partners in this process. I think that we had some initial skepticism and maybe even anxiety from partners that has turned from cautiousness to much more enthusiastic support over time, and would welcome the opportunity to talk more about that. Last slide, if you could, please, Gregory. The last thing I want to talk about is our other medical debt initiative, because this has also been a source of a lot of excitement for us. We were funded, and I want to give credit where credit is due. One of our health systems, we applied to them for a fairly generous award of $250,000 to support our being able to launch a more patient-level, patient-centered medical debt project while we were addressing medical debt at the broader health system level. We also wanted to be able to respond to those hundreds of patients that told us that they had $1,000 or $5,000 or $25,000 worth of medical debt that was currently sitting on their credit reports, or that they were receiving medical bills around. And so that health system, I think somewhat progressively, agreed to award us those funds, and we were able to hire a team of bilingual navigators who, in addition to screening patients for benefits and helping to coordinate connection to other community resources, are also helping to navigate clients through the process of applying for financial assistance. In this first year, we launched the program in July of last year. We have been able to secure $3.7 million in debt relief for 862 patients through that program. In addition to that, almost $4 million in debt mitigation, we have also been able to offer 7 different events where we invited patients in to offer them some really tangible, practical financial assistance, linking them up to other community resources that were helpful to them, and where they wanted it, providing workshops on things like how to apply for financial assistance, how to repair their credit, how to understand the credit system, and how to get banked if they were unbanked. We started out working just with our members. In our second year now, we've expanded to serve all county residents. And right now we're working with some of our partners who serve seniors on expanding the program specifically to seniors. We also were able, with that funding, to create a video that is intended to tell the story of how we can help with medical debt care to the broader community. And as I turn this over to our partners, I will ask Gregory if you can launch that video to share a little bit more about this project. Thank you so much.
My pleasure. I'm just gonna play it, just make sure the volume, please reach out if the volume is.
Overwhelmed by medical debt? Finding yourself in this situation can be stressful and scary. But you are not alone. 1 in 3 Americans struggle with medical debt. Medical debt can hurt your family's credit, makes it difficult to afford essentials like food and rent, and causes people to delay critical health care. DuPage Health Coalition is here to help. Did you know that DuPage County hospitals and many doctors' offices provide financial assistance, even for families with incomes much higher than the poverty level? The most important first step is to ask for help. Medical Debt Care DuPage, a DHC program, makes that easier. We help insured and uninsured DuPage residents struggling to pay their healthcare bills. We'll help you apply for financial assistance and connect to resources like healthcare, medications, food, utility assistance, dental treatment, and mental health care. Every one of our neighbors deserves excellent, affordable healthcare, and our partnerships make it possible. Please reach out today. We can help.
Thanks so much. I will share that video is available in English and Spanish both, as you might expect, given our patient population. But we thought for this audience, English was probably the better. But thanks so much for our opportunity to share a little bit more. Thanks, Gregory.
My pleasure. And I just shared the link to your point, Kara, the landing page for that video and just the language accessibility as well. But for now, I'm going to transition to our second community expert, and I'm going to introduce Samantha Cornell, the Director of Community-Based Initiatives at Access Health in Muskegon, Michigan. So Samantha, if you wouldn't mind coming off mute, and I can pass it to you.
Excellent. Thank you, Gregory. Can you hear me okay? All set?
I can hear you. Are you off? I'm just, the face I'm making is just because I don't see you, but that's okay. Perfect. It's just
I apologize.
No worries. No worries.
Wonderful. Okay, there we go. Thank you.
Thank
you so much. And thank you for the opportunity. To our colleagues in DuPage, just is so inspired, continue to be inspired by the work that you do, and love the opportunity to see how the same work shows up, the commonalities and then the unique features across, two communities that have both commonalities and unique features. Thank you to RAP for the opportunity to be a community impact partner. This has been incredibly meaningful for us as an organization, as it's helped us to increase the areas where medical debt shows up in our work and expand on that, but also to our community who has been so deeply impacted by the work that you do. And to CJA for truly making this all possible and really continuing to lift up that work that's done at the community level. We're a little biased as a community organization, but I can say that is so meaningful and so inspirational and just so important. So thank you for being the consistent voice of that work. Thank you. Perfect, Gregory. I'll tell you a little bit. Access Health is in Muskegon, and if you've ever met somebody from Michigan, you know that we show you where we live on our hands. So I thought it'd be fun to do here. You'll see we're right under the pinky there is Muskegon. Yes, and just to the left in that white area, that's Lake Michigan. It's really gorgeous. If you haven't been there, it's definitely worth a visit. Muskegon is a former lumber town, and then the lumber was gone, and that created, early on we had some adventures, moved into a manufacturing base, and now as a community, or we're really moving into the service industry and tourism, starting to get our feet under us there. But we are truly a smaller community. We have an urban core for sure, but we also have a lot of out-county rural areas. And notably, the decision-making on the state level happens far from Muskegon. It happens more over in Lansing towards the middle. And then, of course, you're all familiar with Detroit there under the thumb. We originally, about even as recently as, within the past 10, 20 years, had 3 health systems, multiple hospitals. We now are down to 1 health system And while going into COVID, we had 2 hospitals. During COVID, that shrunk to 1 hospital. So that has had a significant impact on our community, on our residents, and on straining systems. Within that health system and the systems work, regionalization has occurred. You know, we're seeing that happen within systems across the country. That happens here too. And the decision making has really, well, there's still some decision making at the, you know, at the local level. A lot of that decision making and those shared resources have been shifting over across from under the pinky to the thumb. And that's something that really was exacerbated during COVID, right? As health systems needed to pivot to meet emerging need. One of the things that, you know, I'm talking about some of the barriers, and some of the challenges that we face, but one of the things that that's really led to, because there's always a flip side of the coin, is really a continued commitment. And I would say there's always been a strong commitment in Muskegon, but now it's really become an even increased commitment to community-led innovation. When you don't have a lot of resources, you really have no choice but to work with each other. And we've been doing that for years, and we do it really well. And I think that we really set the tone for how that can work. Can we, next slide, please? Thank you. So these are some of our challenges. As you've heard a little bit about the community and some of the changes and transitions that we've been through. I'm sure it's not surprising to hear that this has created some disparities. Our county ranks quite low on the health ranking index. We are incredibly segregated. Our emergency room utilization is high. It shows up in our health outcomes. And that, as we all know, sits side by side with medical debt. So we have a lot to work on. Next slide, please. Thank you. Alongside of that, though, we have what we would call locally bright spots, because as we talk about those challenges, that's never the whole picture. It's not the whole picture in Muskegon. I can't imagine that it's the whole picture for any community represented on this call. We are, while we're small, we're not tiny. We really see ourselves as a right-sized community for pilot innovations. We've been recognized as such at the state level. We have strong multi-sector communication. We work with each other. We see each other all the time. We sit down together. We work through things. We have that commitment to community-driven action. We really have, I have on the early stages here, but really we have some exciting things where I think we're moving past early stages of true community-led research. And a lot of that, within that, we've embedded a real power shift to thinking about the power of data and who owns the data and who collects the data and who gets to hold that data, and moving that more and more towards the community level. And when I say that, I would say that Access Health as a nonprofit, it should go more community than us, right? It's not just us holding it. It's even more at the community level, neighborhood associations, grassroots associations. And we dream big, we try things, and sometimes that's an opportunity to learn, but a lot of times it works too, and we're able to sustain it. So we've really been audacious. We continue to be audacious, and a lot of those projects have been sustained, and that's pretty exciting. Thank you. So a little bit about Access Health and who we are as an organization. If you're have been a part of CJA, you've probably heard about us over the years. But we were created by the community for the community in 1999 to really impact some of those barriers to improved health in Muskegon County. And within that, it was a cross-sector team. We've been doing that for a long time, but they dreamed big, and they decided to create a coverage plan. And not only did they create a incredibly robust coverage plan, but they worked with community to create a solution that truly worked for the community. So it is eligibility based. It's 134 to 355% of the federal poverty level. It's comprehensive, affordable coverage. I will say that we were certified by CMS. We were the first in the nation to be certified as meeting the minimal essential coverage requirements. And that's incredibly exciting. We've recently had an actuarial study by the state of Michigan. And if you're familiar with metal tiering, we were gold and we're really on the cusp of platinum. So it's incredibly robust coverage. Within this plan, we have embedded a approach that directly addresses the social determinants of health through a process that aligns and streamlines community services. And in addition, what's missing but is critical here is that it's truly in partnership with the individual. It's not just a referral process. It's truly a partnership, relationship-based, one-to-one working together. In addition to health coverage, it truly is in many ways an economic mobility tool. We partner and work with small businesses and really support their efforts to attract and retain employees. Next slide, please. Thank you. So this is a little bit about the coverage model. And I will say that we've been doing it for 24 years. Every time I present, one of the things that somebody asked me is this real? Can it really be done? And the answer is yes. Totally appreciate and get the question. We've been doing it for 24 years. So we're pretty confident at this point. It's $72 a month from the worker and the employer. And just a little bit, I won't read the whole slide, but the key things are no deductible, incredibly low cost sharing. Robust network accepted by 97% of the providers. We talked about these other things. And one exciting, really emerging thing is we have just recently become an anchor intervention in the NIH Compass project, which is the first time that NIH has partnered with community organizations to really address those structural barriers to health. So we're incredibly excited about that and looking forward to the opportunities that that brings. Next slide, please. Thank you. So as you can tell through this work, as we're navigating cost barriers to care, right, and other barriers to care, but within the health plan, that's really centered and focused on cost, right? That's that first barrier that we're addressing, both for the businesses who aren't otherwise able to provide health coverage, and for the individual who, if they were able to provide health coverage, it would be high deductible, high cost sharing. So we've been navigating and talking about medical debt for a really long time. As this opportunity came about, and thanks to RIP and CJA for really bringing that together and bringing that to the community level here. As that came about, we were starting to talk about medical debt as an SDOH barrier. So this was just perfect timing for us. This project did really, it started out a little bit more quickly than anticipated with medical debt abolishment. So that, we were kind of building the plane as we were flying it. The partnership was incredible. But we've really kicked off with abolishment of $25 million of debt for 40,000 individuals. It coincided with the launch of the partnership. We did have some adventures due to that regionalization and having to pivot and reframe that our local partners, it's just within health systems, we all see this, right? But it's inspired a tremendous amount of community conversations and really a continued close partnership with the health system as we work to think about how can we do this on a local level. We continue to work as an organization and a community to move that work upstream. Next slide, please. Thank you. Medical debt at Livability Lab. This is another opportunity that we have brought this back into the community. This is something that we do every year. It's Muskegon County's accelerator for community-led action. We get literally 200 people into a room, residents, grassroots organizations, traditional stakeholders, and non-traditional emerging stakeholders to come in, roll up their sleeves, work together. And the really inspiring thing is that our traditional stakeholders come into the room not to lead, but to listen and to support. And to really prioritize, we don't call it this, but it's really SDOH prioritization and then 100 days of action. So this, within the last lab, we had a medical debt team, and within this lab that's launching now, we have a team that will be launching a public policy forum, truly community-led, to take on medical debt and to start to really evaluate policy opportunities. Next slide, please. Thank you. So this is, I don't want to belabor this because I want to be respectful of time, but I also just want to point out that through this partnership, through learning more about what our colleagues in DuPage are doing and working with the incredible RIP medical debt team, we've really been able to embed medical debt work within so many aspects of our work. We've held focus groups. We're working across the community to really recognize medical debt as an SDOH and start screening. We're even working with partners in other communities across the state to explore opportunities to embed that within the screenings, to really understand the relationships there. Working on that public policy forum. Moving upstream, bringing this into health coaching, into that relationship-based SDOH impact. And then really working on employer-engaged health plan education, developing tools to support health plan selections. It's exciting for us. We are honored to be a partner here and just incredibly grateful for the work to continue to expand this work within our community and beyond. Thank you.
Thank you so much, Sam. Thank you, Kara. Thank you, Sam. That concludes just the presentations we wanted to kind of use as a prompt to not only kind of elaborate on the work that we've been doing, but kind of prime the pump for the questions that we're continuing to explore, as I think both partners kind of reiterated that this is a 2-year commitment that that RIP Medical Debt and Access Health and DuPage Health Coalition have been endeavoring on. So we're halfway through. We've learned a lot, and we wanted to impart some of that learning and engage the CJA membership community. So with that being, I wanted to just introduce and open up the rest of the call, and I know for discussion. So this is very much to engage across organizations that are presented, but also to really get at questions, concerns, strategies, and thoughts that people have regarding what is going on in medical debt in your experience and from what you've heard from the presentations. I do know that we have Sarah, if you would, Sarah was monitoring the chat, and I know there was a few questions in the chat as well. Appreciate everyone's registration, timely registration. We also had a few questions in the registration that have come up that we wanted to at least frame and kind of begin the discussion on. So Sarah, if you wouldn't mind just fielding just the questions that have come up in the chat, and just reiterating a few of the elements that came up from the submissions and the registration, please.
Sure. Yeah, thank you, Gregory, and thanks, Kara and Sam, and everyone who's participating. Our first question in the chat is from Lynette, and Lynette asks, can you share more details about how the health systems are partnering with DuPage Health Coalition to reduce medical debt? So, Kara, I'll turn this first one to you, if that's okay.
Yeah, I absolutely can. So on the RIP side, I will share that the way that process goes, there are a number of steps. And this is really driven by sort of RIP's tried and true experience working with other health systems, and we are adopting that practice. So what has happened, and one of the success strategies that we have found especially helpful, we really used our boardroom as a pathway for building connection between RIP and our health system partners. I said that we launched that survey. That survey was actually a very powerful tool for our board members, because I think that my board is comprised of C-suite leaders from all of those hospitals. So that's helpful for us because that means that we already have those relationships and we have those ears. But I think that they believed that they would find that members of our programs were somehow exempted from the experience of medical debt. And it was a sobering learning for them that either members themselves still were experiencing debt and gaps in the ability to receive the necessary financial assistance, or that their family members were still substantially The way that these partnerships are therefore working is that we are bringing RIP into conversation. We are educating the partners about the reality of where our patients and the broader community is finding themselves. We are making sure that as we're having those conversations, we're doing so in as non-judgmental a way as possible. And that's really fair, by the way. The truth is that most people wake up most days with the intention of doing things in the best way possible. And there aren't a lot of evil, malevolent revenue cycle folks out there trying to ruin the lives of our patients or others. But the truth is the system is failing patients time and time again, and needs to be substantially reformed. So we bring the RIP team members into my boardroom, both literally and figuratively. We have used the boardroom as a way to introduce the opportunity for partnership. And then we have taken that broad opportunity and gone one-on-one into each of those health systems to have more intimate conversations. We've used our partnerships at the board level to then have deeper conversations with a wider array of leaders at those health systems, and to try to sort of continue to keep an open door to those conversations. And like I said, we found very early success with 2 large health systems that just said, honestly, in one meeting in both cases, this is the right thing to do. This makes sense. We want to do it. Where do we sign up? The yes was not hard. Getting from the yes to actually landing the plane has been substantially more difficult. And actually, I did invite RIP partners to talk a little bit about that. IT queues are a nightmare. Every health system in my county has gone through a merger in the last year and a half. And if they have, and they're probably going through another one as we speak. And every merger means that they're putting together 17 different systems and getting on their priority list. As much as we may be talking about $1 billion worth of debt and the potential upside in some cases of hundreds of thousands of dollars of, that could potentially be changing hand with these medical debt buys, these are large balance sheets. And honestly, the dollars and cents are probably not the governing decision makers for them on these. This has to be more governed by other factors, because we are not finding that our health systems are particularly motivated by the dollars and cents of the transaction. You have to sort of approach it from a multifactorial standpoint. The other answer to your question in terms of how we are partnering is probably around that second project that I spoke to, which is our one-on-one relationship building as it relates to particular patients' medical debts. Like I said, this is work we had always done in a less structured way, but part of the work that we've been doing now that we have more team members that are dedicated to this process is really diving deeply into, on a policy level, understanding the way that each of our systems' financial aid policies and practices are working, and trying to be advocates for making those systems work better. And that's the place where not only are we trying to work on an individual client's debt outstanding bill, but also say, hey, are you aware that this piece of your financial assistance application is deterring a lot of people from submitting the application? Or patients are failing in the process here time and time again. Might we look at a different way of doing this? Or Hospital X, did you know that your system is different than every other health systems in this particular regard? You're kind of an outlier here. Did you intend to be? And some of those conversations are sensitive, but again, it helps that we have 20 years history of partnering It would be a lot harder to have that conversation if we only ever had difficult conversations with them, instead of having a lot of conversations that are actually really collaborative and mutually respectful. So those are just a handful of the ways in which we're working together.
Thank you. Thanks, Kara. I'm going to jump to one of the questions that we received in the registration prompt to understand what questions are coming up for folks who are participating. And I'll ask this for everyone, including RIP, if you'd like to respond, Sam and Kara as well. What are the best practices for hospitals to prevent medical debt? And how should the rev cycle be structured to reach those who need it?
For reference, so RIP Medical Debt in this partnership has an extensive, we've deliberately partnered with our with CJA, right, to steward relationships with community CJA members because of the proximity they had to the communities that they serve, and the more, as to Kara's point, the extensive tenure that they have in the community and with the hospitals. I was wondering, actually, Jessica Curtis, our consultant, just if you could speak to, so we have a whole revenue cycle team that I would love to have on the call to kind of address that directly. But for now, I wanted to just pinpoint just some high level immediate reactions to that. And Jessica, I'm wondering if you would be able to just weigh in on that. We've done some pre-existing work, but we're also exploring other work. If you had anything to add.
Sure. Thank you, everyone. So I would add, and I will put in the chat, a link to 2 issue briefs that are already public. One is called Insurance Alone is Not Enough, that RIP did in partnership with Neighborhood Health Financial Partners, a nonprofit financial services organization. And that includes some specific recommendations for hospitals as well as for employers and insurers. And some of the top line recommendations that you can see in that report include evaluating an upgrade to your financial assistance policy that is at least eligible for anyone who is at 400% of the federal poverty level or below, whether they have insurance or not, because that's often a common gap that you'll see a pretty low income level or a policy that's more generous but only applies to the uninsured. Our recommendation is 400% federal poverty level at a minimum, and then regardless of insurance status. So that's one recommendation for hospitals. And then Kara, I think, touched on this point, that there's also a difference between the policy and the implementation of the policy. And so one of our recommendations is also to really go through with a quality control perspective to the application process itself. Look at the scripts that your call staff and any vendors are using if you're a hospital system, and really think through from a patient perspective, what are people hearing? How are they being directed towards financial assistance or towards bill payment, which is a common strategy, right? Is, can you put a little bit on a credit card today? You know, can you find a little bit of money, instead of maybe directing people towards financial assistance? So those are 2 of the recommendations. There are more. I'll put that link in the report. But then the other thing I would say, and this is where DuPage and Access and others on the call might have recommendations, is there are some common recommendations we can make, but what's really going to work locally is dependent on your community and how your community functions and what your community needs. So if nothing else, the most important thing hospitals can do is build relationships with organizations like yours who see those problems and issues firsthand. So I'll turn it over and see if others have ideas.
Samantha, if she has any ideas first before I speak.
And Sam, I was also going to prompt, your experience with the regionalization that you mentioned in your presentation comes up for me, having worked with you alongside this issue, just the ways that, and I know that others on the call are facing that, just comes up for me.
Yeah, absolutely. I think that's a great question. And I'll answer because I think the regionalization is a great aspect. And then there's one way that I want to say is easy. I know it's not that easy. But one way that I think would have a quick, meaningful impact. And I know, again, it's not that easy. But from the regionalization, that's something that we're seeing within health systems, and we're seeing within other systems too. right? It's not just health systems, but where we see it show up in our work is health systems, where and for us, COVID exacerbated it. Where the financial resources team was that those financial services team that was local to our community, and now it's been moved over to the east side of the state, which for a lot of reasons makes a lot of sense, right? But then it precludes that local decision making to unique aspects of a community, and it also precludes trying something, right? It's a lot lower risk to try something within one hospital and one community than it is to try it across the whole state, right? Your risk is magnified. So when that decision making has shifted from being both local in scale and local in consideration to a state or a regional level, it really does mean that decisions are being made just one step removed, because I think the point is great that these are good people coming to work to do good things, right? There's reasons that these decisions are being made, but as we remove from the community and from that direct impact, it does shift that decision making. So whatever we can do to help, knowing that the world's going in the way that it is and regionalization is going to happen, what opportunities are there to still build those connections where you're truly having those conversations with those impacted at the community level? Additionally, one thing that we are seeing showing up, and I know others, I was at a conference Monday, others across our state are seeing showing up, and I am certain that it's not just within our state. I think this will resonate with everybody, but is that having medical debt at the health system level is often now a direct barrier to accessing care. So not just a chilling effect, not just I'm going to avoid care because I don't want to run up my bill, but literally I have a debt, I cannot obtain medically necessary care. I can understand the reasons for it, but the impact of that is devastating. And truly is going to expand the risk, as now we're driving people to truly, emergent care, which we all know is going to be more expensive. So I would say that is something that is, I know it's not easy, but that's something that I think could really be addressed as an initial step, or certainly as a conversation point. I think it's something that people could relate to too. Those are poignant stories, which of course need to be treated appropriately. But I think access to care is something that everybody can understand the need for.
Thank you so much, Sam. We're being cognizant of time. I want to wrap up a few points, and then we have a few resources to share to close out the call. I wanted to transition just to end the call as we started the call with an invocation from Gary. Gary, if you wouldn't mind just sharing out some themes and commonalities that you're noticing from the presentations and the discussion at hand, knowing that we also have a second learning call coming up in December, where we're going to build from everything that's coming out of today, kind of couching it in the next learning call. But Gary, if you would, just some kind of closing invocation.
Yeah, I appreciate that, Gregory. Minus the song and dance choreography that I suggested before other folks jumped on the call. It, again, has just been a thrill and an honor to spend time with the change makers that presented today. I'm reminded that every day 1 in 2 Americans choose between paying medical bills and covering basic needs. If not for the folks who are on this call, CJA members from California to New York, from the fingertips of Michigan to the cowboy boots of Texas, those folks might not have hope, right? But we have in this room champions of change. We have those who are champions of serving the un- and underinsured. We have this wonderful opportunity to eradicate medical debt that is not a lofty pie in the sky idea, but it is having roots and it is having great effects in the communities that you've heard from today and many others as well. I'm inspired by the power of partnerships that folks have talked about, by the power of board of directors to be the ignition of change in local communities. And I'm inspired that even with all the stuff that might be going on in hospitals, hospital systems, mergers and acquisitions, regionalism, if you will, that we keep true to who we are and to our mission, and we choose how we respond to that, and we're responding to it in positive ways that are having positive outcomes for those that we serve. So thanks again.
Gregory, I think you're muted.
Thank you so much, Miranda. Miranda's also a wonderful partner. Let me just take a moment. But I'm gonna close out the call. We have we have our second learning call. So this series was, again, we're trying to survey just the not only the interests, but the ways that most CJA members are doing work in, if not around, medical debt, right? From the registration, we already knew the majority of the people on this call see the impact of medical debt in the ways that it delays care, just generally, right? And we know that those stories get more nuanced and more explicit as we move. So I just want to put a plug for now. We have our learning call on December 4th at 4 p.m. Eastern, which is a Monday. There will be more information fleshed out, but we're going to try to scale up this conversation where we've kind of touched on institutional relations, right, between organizations and hospitals. We didn't talk at length about community, stakeholders, but like we're going to scale up to kind of think about the ways that policy can now mirror these programming elements that we're trying to move the needle on and trying to track the impact of. Finally, I want to just share, we have a kind of a live toolkit of sorts. I just shared it again in the chat. For now, it's a Google Doc. Toolkit's a little, formal, but we have a live document that we really want to encourage some discourse within, not only to couch resources, but again, to encourage some questions that will maybe bridge the themes that we're seeing today with what we're going to flesh out further in December. This is a live conversation. With live learning, with partners on the call, with a membership, an extensive membership, right? A CJA membership that's national, that networks really deliberately with some great results. So we don't want to miss the opportunity to kind of engage this conversation further. Please reach out to me. My email has been, who's been in your inbox, kind of getting everyone to these calls with any questions, but I will share contact for any explicit networking that you would like to pursue further. But for now, please refer to the toolkit for resources and also questions that you may want to pose for the interim learning calls. I want to acknowledge everyone's contribution in showing up, but everyone's contribution also in presenting. So thank you, Gary. Thank you, Communities Joined in Action. Thank you, Sam from Access Health and her team. Thank you, Kara and your team from DuPage Health Coalition, and my team at RIP, our consultants as well. I hope everyone has a lovely rest of their day. And I will be following up with the recording of this and the slides for reference. Again, please reach out. I'm Gregory Brody. I'm the program manager for community engagement at RIP Medical Debt. I hope everyone has a lovely rest of their day. Thank you so much.